Welcome, everyone. We're going to give all of our attendees a moment to join us and get settled, and we will begin our presentation momentarily. All right. Welcome, everyone. Thank you so much for joining us tonight for our first live panel event, The Case for Medicare for All. Tonight's event is sponsored by Physicians for a National Health Program, Minnesota. Physicians for a National Health Program, or PNHP, is a national education and advocacy organization of over 8,000 health professionals and patients who support universal health care through single payer reform. Our vision is a Minnesota where all patients get the care they need, and our mission is to educate, advocate, research in order to build a single payer health system that achieves health equity for all Minnesotans. My name is Jen. Welcome to Zoom. This is our new format during this time of social distancing. If you have any issues tonight during our Zoom webinar, please feel free to submit them to us in the chat button at the bottom of your screen. If you would like to submit a question to our panel at any time, please feel free to click on the Q&A button. And during screen sharing, if you have any trouble seeing the full slides, please feel free to click on the view option at the top of your screen. Our panel tonight consists of local medical professionals that will share their commitment to our motto, patients before profits. We are honored to welcome Rose Roach, the Executive Director of the Minnesota Nurses Association. Rose has 30 years of experience in the labor movement, as well as 15 years experience in health policy advocacy in Minnesota and California. She is a national speaker and advocate for single-payer healthcare. PNHP Minnesota's own board member, Dr. John Crossan, is a semi-retired pathologist who spent the majority of his career at the Hennepin County Medical Center. Dr. Crossan has been working on single-payer issues for over 25 years, and tonight he will share with us studies dedicated to the financial costs and human costs of delaying Medicare for all. Ms. Carrie Carlson, also a PNHP board member, recently graduated with her Master of Public Health degree focusing in health equity and environmental health. She is now working with a federally qualified health center serving the Northeast Minneapolis and surrounding communities. Unfortunately, Ian Durbin will not be able to join us due to a family emergency, and our hearts absolutely go out to him and his loved ones this evening. Finally, we are so thankful that Jenna Robinson has agreed to join us today and share her insight into the need for Medicare for all. Jenna is a first-year medical student who will be dedicating her life to the wellness of others. Tonight, she will share with us her vision of the future of healthcare with single payer. So again, we thank everyone for attending this evening, and we will open with Dr. John Crossan and a brief history of Medicare for all. Hi, John.
Yeah, I'm ready here. I've got to find, here we are. Okay. Does this show?
Yes, we can see your slide, sir.
Okay. Many of you have heard recently about Medicare for All, in particular from candidate Bernie Sanders. And you may think that this is a brand new idea because we've just really begun to hear about it extensively. I wanted to emphasize that this is not a new idea. Teddy Roosevelt back in 1912, when he was running for a second term as a president of the United States, began talking about a national health program. And of course, it went nowhere during that time. In the Second World War, his cousin, also a Roosevelt, began to talk about national health insurance. And unfortunately, our Franklin Roosevelt was not able to see the end of the Second World War, and the presidency was taken over by Harry Truman, who in 1947 began pushing very extensively for a national health insurance program. And again, nothing happened until the early 60s when John Kennedy took up the effort and began to talk a lot about national health program. And finally, his successor, Lyndon Johnson, in 1965, was able to sign the Medicare bill for people over 65 years of age. And interestingly, the first two recipients of the Medicare were Harry and Bess Truman, who were really the people who began to really talk about this. At the time the Medicare bill was signed by Lyndon Johnson, the idea was that Medicare for all would eventually come about. This was meant to be an initial effort to get Medicare coverage for everybody, or a national health program. In 1972, this was expanded to cover patients with long-term disabilities, and in particular to cover patients who had end-stage renal disease. Finally, in the late 1980s, Medicaid was added to Medicare. And then in the mid-90s, we heard a lot from the Clintons, led primarily by Hillary Clinton, to try to get some sort of national health care system, but that was completely squelched. In 2006, George W. Bush brought in Medicare Prescription Part D. And then finally in 2010, the Affordable Care Act was signed in by President Obama. I'll be talking a little bit more later about the Affordable Care Act, but I thought it was important for people to know that for well over 100 years, we've been trying to get a national health program in the United States, and have so far been quite unsuccessful. So we want to proceed with these efforts that have preceded us, and hopefully within a very few years, we will have single-payer healthcare in Minnesota and in the United States. So I'm going to turn this over now to Rose, who will give us some idea of what Medicare hopefully will look like in the near future. Rose?
Thank you, Doctor. Good evening, everybody. It is a pleasure to be here with you tonight. I'm always so proud to represent the nurses when we're talking about how we can better guarantee healthcare for all, because as we know, healthcare is a human need. It's a public good, and it should be treated as such. And I don't think there's any time in our recent history like the one we're in right now that makes that very clearly obvious. It is good to be talking about something other than COVID-19, although I do think that it makes it very clear in this global pandemic that you really can't run a healthcare system like a business. When healthcare seems to look at the auto industry to determine ways to operate hospitals with ideas such as the lean management model, which is premised on the theory that we keep staffing costs down while we keep profits up, they're putting patient care at risk, and that's unacceptable for a healthcare system as far as the nurses are concerned. You add to that the fact that we tie healthcare access to an employer-based insurance model, and now we're adding tens of millions to the uninsured ranks as people lose jobs during this pandemic, and it becomes crystal clear that we can't just tweak our healthcare system. It needs to be overhauled with a focus on patients and on health. And that is what I'm here to talk to you about tonight. So next slide, please. So what is the problem with our current system? Well, basically the problem we hear is that healthcare is too expensive. So what is the solution that we've come up with? It's to make it more difficult to get. So we have all of these different things that are put into play that are all created by the insurance industry, which are all about things like limited networks. So now you get a book, you get told who you can go see, which physicians, which clinics, which hospitals. That's all created out of this type of a insurance-based system. That doesn't exist in countries that recognize healthcare as a right and a need for all of its citizens. We have co-pays and deductibles. One of my favorite sayings that I hear out there is when they say, well, if you just had a little skin in the game. I always say all my skin's in the game. We're talking about healthcare here. So co-pays and deductibles have been shown time and time again to be something that will discourage people from actually seeking healthcare. And that does not get us to where we want to be. We want people to get healthcare when they need it, not just based on ability to pay, so that we can have a healthy society overall. They restrict coverage. So this is one of those things where you can buy a plan that has some things covered, not other things covered. I remember when they were debating the Affordable Care Act, there were some men in Congress who said, why should maternity leave be something that is covered under as an essential benefit? I'm never going to be pregnant. Well, I would argue that, you know, everybody was started out as a fetus, so we should care a little bit about maternal care and prenatal care. And then there's prior authorizations. I'm sure the doctor would be more than happy to tell you about how much time is spent dealing with insurance companies just to get people what they need, the care that they need based on the doctor's professional, you know, examination of us. So 40 years of reform has gotten us really, has made it more difficult for us to get care. I think that you've had a couple slides on this. There you go. Go back to the next slide, please. So what has that gotten us overall? You can see here where our life expectancy in the United States of America is actually going down for the 3rd year in a row. Can you imagine the richest nation in the world, and this is pre-COVID, and our life expectancy is actually going down. So we are spending plenty of money, but are we actually getting any bang for our buck? Next slide, please. It's interesting to see that we actually are already spending a great deal of taxes and publicly funded for health spending in this country. When you look at it, it is over about 65% of all the dollars involved in our healthcare system are already funded by all of us in one way, shape, or form, be it Medicare, Medicaid, the Veterans Administration, health benefits for public employees, the tax subsidies that go along with the Affordable Care Act. All of those, when you add them together, add up to 65%. So the question becomes, if we're already basically paying for a healthcare system, why isn't everybody able to access it? Next slide, please. As I come out of the labor movement, we very much care about the increasing costs for workers. And you can just see in this slide that what I kind of refer to as the mouth of the alligator there. You can see where the health insurance premiums is sort of the yellowish gold line. Workers' contributions to premium is the one that's just above it in the darker blue, with workers' earnings being the light blue and overall inflation in the gray towards the bottom. That is not a sustainable model economically for this country. It isn't for a government, not for employers, nor is it for families and employees. Next slide, please. Speaking a little bit about the global pandemic, I just think that this is a valuable quote for us to think about. It was written by Steffi Wohlhandler and Dr. David Himmelstein. They are co-founders of the National Physicians for a National Health Program. And they say that although the COVID-19 crisis demands urgent action, it also exposes the imprudence of tying health insurance to employment and the need for more thoroughgoing reform. A trickle of families facing the dual disaster of job loss and health insurance loss can remain under Washington's radar. However, the current tsunami of job and coverage losses, along with a heightened risk for severe illness, demands action. A decade ago, Victor Fuchs forecasted that national health insurance will probably come to the United States after a major change in the political climate, the kind of change that often accompanies a war, a depression, or large-scale civil unrest. Such a major change may be upon us. And I think that is exactly right. Next slide, please. So where is a lot of this money going? Well, here's where some of it's going. You can see the health industry profits overall. You've got the pharmaceutical industry at $72.7 billion, and we don't have the latest data in yet for 2019, so this is the most recent data that PNHP has for us. You see the insurance companies, $22.1 billion, equipment and supplies at almost $12 billion, providers $4 billion, distributors and wholesalers $2 billion, and then pharmacy lab benefit managers at $1.3 billion. So this is where our for-profit health insurance, medical complex is spending or taking some of our precious premium dollars, and this is where it's actually end up going in profit. This is profit. This is not what they're making overall. This is after they've paid out the expenses. Next slide, please. One of the slides that when I show it a lot of times people are pretty in awe of it is the fact that when we look at our healthcare system from 1970 to 2018, we see with the yellow bar towards the bottom there how many physicians have entered our healthcare system during that time period. That ends up being about 100% growth in physicians, but that sort of, I don't know, aqua bluish color is actually administration and managers and people who process billing for both the hospitals as well as the insurance companies as well as in the clinics. We have actually increased over 3,000% the number of people who are actually working, pushing paper, and are not actually providing any kind of health care to individual patients. Next slide, please. This, I think, is a striking headline. Goldman Sachs asks in biotech research report, is curing patients a sustainable business model? That seems to go against everything that we believe a healthcare system should be focused on. And it is disturbing, to say the least, that they would just come out and admit that that's really where their focus actually is. Next slide. From the nurse's perspective, a healthcare system shouldn't be about their wealth, and you can see it here, health insurance company CEO compensation from 21.1 million, 27.2 million, lowest at 8.3 million, and then you've got the pharmaceutical CEOs as well. When you've got healthcare CEOs that were paid $2.6 billion in compensation, with 1 in 4 Americans skipping medical care due to cost, we have a very clear injustice that is happening within our healthcare system. The reality is I don't believe any of those folks that I'm aware of have healed anyone for $21 million, and I don't know a single nurse or doctor currently that is making $21 million a year to provide healthcare. We should focus our dollars on getting healthcare to human beings. Next slide, please. And that's why it should be strictly about our health. So next slide, what is to be done? One of my all-time favorite quotes by George Carlin: I don't believe there's any problem in this country, no matter how tough it is, that Americans, when they roll up their sleeves, can't completely ignore. I hope that's not true. I think we can do better than that. So let's take a look at what that might be. Next slide. What you see here is the current healthcare system. This is literally what it looks like sort of when you try to do some sort of a flow chart of where the money starts and where it goes and how to get it to who we want to get it to, which is our care providers. That seems awful convoluted. It's very fragmented, and it is, quite frankly, needlessly complicated and expensive. How about if we move to the next slide, please? A system that looks a little more like this. So businesses and people pay into the system. It's income based on a premium. And that funding then goes into a public health insurance plan. You get an insurance card, just like you have now. And you use that when you go to a doctor's office, a hospital, whatever. And then the provider simply goes in turn just bills that public insurance health plan and is paid. It really doesn't need to be a whole lot more difficult than that. We add layers, we add cost. So why not streamline our financing system? And the system we're talking about that you're looking at on this screen is not a socialized medicine system. This is a publicly financed, privately delivered healthcare system. So the hospitals, the clinics, they still remain in the private sector. Next slide, please. What are some of the benefits? What does Medicare for All really mean and what does it look like? Number one, it covers everyone, no exceptions. It covers all medical needs. If it is determined that you have the need for it, it's medically necessary, it's covered. Right now, we don't consider dental, vision, in some cases, mental health, long-term care, substance abuse treatment. Those things aren't seen as medical needs. Nonsense. Of course they are medical needs and they should be covered under a medical healthcare system. Choice. We often hear, oh, geez, I don't want to lose my choice. I'm not sure about everybody else out there, but I have very good insurance. I'm very lucky, but I don't get to choose to go anywhere I want. I get told who I can see, what systems I'm able to access my care through. I would like to be able to choose that based on who I want to see, if I do some research or whatever, and go to my local doctor or my local hospital. Choice should be there, and choice is about what Medicare for All really is all about. We want to reduce costs, but not by cutting administration, excuse me, but not by denying care. That should not be the way we save money within a healthcare system. The coverage moves with you for life, from job to job, state to state. So it is portable, and that is important for folks to be able to expand, to start a business, to move to another city or state that they want for whatever reason it is that they want to make that move. Community hospitals and clinics will have more reliable funding so that they can stay open with their high quality staff and resources accessible to them. And there is much more support for healthcare in the underserved and rural communities. A lot of people say, well, if you go to this system, we're going to have to close all of the rural hospitals because they'll never be paid enough to stay open. Rural hospitals are being closed now on a regular basis. They're not based on the needs of the community. We need to do regional health planning, and we're able to do that under a Medicare for All system that focuses on the needs of the community. It becomes affordable to all because it's premiums that are based on income. It focuses on preventative care. We make sure that we have enough providers to avoid waiting lines, pay the providers in a timely manner and fairly, and it's a simple and understandable funding payment system, which would make life a lot easier for many of the folks involved in this system. Next slide, please. So hospitals, how would they work under a national health program? Well, they remain privately owned and run, as I said earlier. They negotiate with the government entity for global budgets for all of their operating costs. And then operating funds can't be diverted to capital because they get a separate fund for anything they need in capital purchases. So if they need to expand their hospital for whatever reason, add sort of a cancer center, another lab of some kind, then they petition for that under their capital budget for the year. And then as it is researched and looked at for that community, if it is necessary, then it is provided in a capital budget for that hospital. Next slide. Global operating budgets are really the key to single payer. It cuts the administrative costs down. There is Duke University has a hospital that has about a little over 900 and some beds in it, and it has 1,600 billing clerks. That seems a little bit off kilter, especially when there aren't even that many doctors or nurses that work for that particular healthcare system. It eliminates the disparities in profitability of patients, banning hospitals from keeping the surplus, so it minimizes the entrepreneurial incentives and instead of incentivizes the needs of the region and the community around their health. And funding capital through explicit grants minimizes unneeded duplication of expensive equipment and services as well. Next slide. So three options for physicians and ambulatory care payment. So people wonder, how are the physicians going to be paid? How will people be paid under this system? Well, it's broken out into three different categories. There can be fee for service with mandatory assignment and simplified negotiated fee schedules. For instance, in Canada, the physicians regularly negotiate what their fees should be for the services they provide with the provinces and their individual healthcare. I'm trying to remember the official name of them and it's slipping my mind at the moment, but they have a healthcare agency that sits down and negotiates those fees to make sure that physicians are always compensated well and that for sure all of their costs are covered. Capitation happens for a lot of the doctors and the nurses who work inside of a hospital. They are paid a salary as opposed to a fee for service. Because they are considered employees of that hospital, so that they get fees they get the money in order to pay for the work of those salaried workers to each one of the individual hospitals. And then there are global budgets, as I had said previously, that are also provided for those salaries. Next slide. So for patients, a single payer transition would mean every US resident receives an insurance card. They get full coverage for all medically necessary care. There would be no co-payments, deductibles, or co-insurance. We would make sure that there's a prescription drug formulary that it allows everyone to get what they need medically, and that alternatives are covered as well, and that there's a free choice of any participating provider or hospital. Next slide. For displaced clerical and administrative workers, folks are concerned about putting people out of work if we no longer had an insurance-based system. And as, again, a trade unionist all my life, I would say I care about workers and I want to make sure that they have a soft landing if in fact they're going to face any kind of layoff or their industry is going to go away and they are going to need to find gainful employment. So what the bills nationally do, as well as here in the state of Minnesota, is allows a certain % of the healthcare budget to be set aside to make sure that those workers are able to get retraining. They keep their salaries for a couple of years while they're going through that training in order to keep them afloat and make sure they can still pay their bills. We would hope that a lot of the folks that are in the health insurance industry who happen to be nurses and doctors would now transition over and go ahead and start working again back in healthcare, providing care and being directly at the bedside once again. So there is support to help these workers transition to new jobs so that they are not displaced out of work. Next slide, please. There are two current bills in the United States Congress. There is Senate Bill S-1129, authored by Bernie Sanders, and House Resolution 1384, which is authored by Pramila Jayapal of Washington State. Both bills have universal coverage, single public plan. They're comprehensive. They do not have copays for covered services. They ban duplicative private coverage, so you could still buy private insurance if you needed it for something, but not for anything that's already covered by the healthcare system itself. There is an exemption for the Hyde Amendment so that women's reproductive health is also covered under this system, and there is drug formularies and an allowance for our government, like almost every other government in the world, to actually negotiate with the drug companies over the price of pharmaceuticals. Next slide, please. The one concern we have with Senator Sanders' bill is he does continue some needless complex payment strategies that he has in the bills. You may have heard of things like accountable care organizations and value-based medicine, value-based purchasing. We think those are really kind of gimmicky and they have a tendency to also, again, cause more administrative waste. We'd rather just move straight to global budgets and capital budgets. So we'll continue to work with Senator Sanders and hopefully get the bill to be compatible with the House bill for global budgets. Next slide, please. There's lots of lookalikes these days out there. You're hearing single payer Medicare for all, Medicare Extra for all, Medicare Advantage for all, Medicare Public Option. Please be aware that they're not all the same. A public option would be very difficult to implement within the current structure because the industry is very, very good at knowing how to cherry pick healthy, healthy plan recipients and patients, and how to drop those, they call them lemon dropping, those who are sick, and put them back into the government healthcare plans such as Medicare or Medicaid. They won't fix the weaknesses in our current plan if we're continuing copays and deductibles. The Medicare Advantage has got some huge problems with it in the way that the industry is literally ripping off our Medicare system, and the provider payment strategies are still in place, which really drives a lot of gaming and abuses. So if we're going to do this, it's time to just do it. We know what the gold standard is. Let's just get to it and make sure everybody has the health care they need. Next slide, please. So I'll just end by saying, who do you want to follow? Do you want to go with the suits or the scrubs? And I know from my perspective, after working with the nurses for almost 6 years and working with them for 15 years on health policy, I know who I'm following, and it is most definitely those in the scrubs, because they're the ones who really care about our health and not just their own wealth. And the last slide, as I said earlier, you can't cross a chasm in small steps. So we must take the time now. This is a great opportunity for us to move to a system that's really going to guarantee healthcare for all. Thank you very much.
All right, thank you so much, Rose. Dr. Crossan, we're going to send it back to you.
Okay, I need to get my new slides up, which I will in just a minute, if you all will hang on.
While John works on that, all of our attendees today, we want to again say thank you so much for joining us. As you hear our speakers today, if you have any questions about anything that they present, please feel free to click the Q&A button at the bottom of your screen and submit those to us. We will be taking questions throughout the presentation, and we've gotten a few really good ones so far, so please feel free to share with us.
I thought I had this up. If you will hang on just a minute, I will get it. I thought I had it already up. There we
John,
are.
I have it up if you'd like to use it.
Oh, okay. Thank you.
Yep, you got it.
Brought it up. Thank you very much. I thought I had it on my screen. Anyway, Rose, thank you so much. That covered all the issues, and actually a lot of the things that you talked about had to do with financing. Is that right?
Yes, sir. Some of it.
Well, I wanted to talk about one article that was recently published in The Lancet. This is probably the top medical journal in the world. It came out of Yale Medical School, from the Yale School of Public Health, the Center for Infectious Disease Modeling and Analysis. Now, there have been a number of recent articles published in this area, and pretty much all of them show the same thing. Wohlhender and Himmelstein recently had an article published in New England in Annals of Internal Medicine, which showed basically the same information. So I'm going to spend a little bit of time on this article. It's a very complex article, and I don't want to go into all the details of it, but are you going to run this for me, Jen? Jen?
Yes, absolutely. Feel free to just say slide, and I will advance it for you.
I'll take the next slide then. You all may not be able to see this terribly well. This is from that article. And the beauty of this article is that it has embedded in it an interactive system whereby you can go and look at uh, their algorithm that they use to come up with the financing, and you can actually put in your own figures if you want to. Now they have a group of different assumptions, and I'm going to, let's go to the next slide. I'm going to go through each of these assumptions in a little bit of detail. The assumptions are actually taken to a large extent from Bernie Sanders' bill. And let me talk about a couple of the different assumptions here and what they are talking about. Let's take the top two first. Decrease reimbursement rates for hospitals and decrease reimbursement rates for physicians and clinical services. Now, this may not sound too good to the people in the medical field, but the reason that this has to be brought in is that there are huge variations in the charges that are made by people in medicine, both the hospitals, the physicians, and the clinical services. The huge variations come about because people can get away with it. The insurance companies are willing to pay a little bit more to keep the big providers in their system. And Rose talked a little bit about this issue of being in the system. If you are in a system of healthcare that is covered by insurance companies, then the insurance companies will say, you can go to this doctor, but not to that doctor. And then if they want to keep the people in their system, then they can pay a little bit more than other physicians and hospitals would charge. Now, the basis of this assumption is that under Medicare for All, we will basically use the charges that and the reimbursements that are covered by Medicare. And so this brings down the total amount of money that people can charge. I want to call people's attention to another book called American Sickness by Elizabeth Rosenthal. And I'll see if this can show, can people see this?
Yes, we can. Thank you, John.
Okay, this book is written by Rosenthal, and she is an internist who trained in the top medical schools in the country. I think she's a Harvard-trained physician. She went into internal medicine, also did some emergency medicine, and about 20 years ago decided this was not quite for her, partly because she was getting fed up with the whole healthcare system. She became a writer, basically, and she's written for the New Yorker, and she currently writes for the Kaiser system in California. This is a very powerful book, and it points out that people can charge whatever they can get away with. And if they can get away with it, if the private insurance companies will pay it, then they can charge for it. And there are huge variations in charges both by hospitals and by physicians, depending on what they can get away with. For example, in the country, there are appendectomies that are charged by hospitals for $9,300, and other appendectomies are charged $33,200. A huge variation in charges for appendectomies. And interestingly, there's an inverse relationship between the amount charged and the results of the procedure. So I want to just talk briefly about one case that Rosenthal talks about in her book, and we'll come back to this in just a little bit. But I want to just briefly tell about a woman in her mid-50s who was the primary breadwinner for her family. And all of a sudden she developed a severe headache. And was eventually taken to the closest emergency room, and turned out that she had a subarachnoid hemorrhage. She ended up in the intensive care unit for quite a while. She had the leaking vessel clipped, and she actually eventually recovered quite well, and she came back to normal. She was back to normal until she started receiving all the medical bills, and the final total for all of the medical bills was $500,000, $500,000. And because some of this was out of system, her insurance did not cover a lot of this. And she spent years trying to figure out how she was going to afford this particular bill. This is the kind of thing that is going on all the time, and we do need to do something about this issue. And so the reimbursement to hospitals and physicians and clinical services would be basically based on what Medicare currently reimburses for these charges. Now, beauty of this is that it standardizes charges. The Affordable Care Act, signed by Obama in 2010, provided some wonderful benefits. One of the things that it failed to do was to control charges and prices. And this then would provide a much standardized way of billing for different procedures. Rose mentioned the pharmaceuticals. Pharmaceuticals, we all know, are way out of line. We in Minnesota have heard about Alex Smith, who was the young diabetic who had to limit his insulin dosage because he didn't have enough money to afford what they were charging him for his insulin, and he ended up dying in diabetic ketoacidosis because of this. This is only one example of the outrageous charges by some pharmaceuticals. So what this does, what this bill would do, would be to allow institutions to negotiate with the pharmaceuticals to get a reasonable price. And the VA is able to actually negotiate prices that are about 40% less than what Medicare actually pays for some pharmaceuticals. And so it is possible to do this. Overhead expenditure. Whoops. What happened? Oh, I'm sorry. No, go back to the assumptions. I'm sorry. There we go. Overhead. No, one back. There we go. No, one back. There we go. Overhead expenditures. Medicare has an overhead somewhere around 2.5% to 3%. Right now, we have overhead in this country in the range of 34%. This is partly because of all of the administrators that are in the institutions that are billing. It's also partly due to the fact that the insurance companies have all kinds of administrative excess, and the administrative charges by the insurance companies are about 12%. Improved fraud detection. It's thought that about 4 to 5% of our charges are actually fraud and can be brought under control. There will be expansion in healthcare use by the uninsured and the underinsured of maybe about 50% increase. There will be revenue generation via payroll tax and revenue generation via household tax. Now, the particular article uses 2017 as the standard, and they compared their expenses based on 2017 expenses. There was about $3 trillion spent in 2017 on healthcare. Um, the idea would be that the companies would decrease the amount of total expenses by from about 12% down to 10%, and there would be increased revenue generation from the individual households from about 9% down to about 5%. This would result in a average savings per household of about $2,369. Sanders is proposing a net worth tax on people who have a total worth of $21 million or more. Actually, Elizabeth Warren has a similar one, taxing people at greater than $50 million. Okay, let's go on to the next slide. This shows that, in fact, there would be a lot of savings in lives based on the fact that uninsured individuals have a 40% elevation in their age-specific mortality, and there would be an overall increase in our savings of about 68,000 lives under Medicare for all. Finally, go on to the next slide. Right now, there's before COVID, there were about 37 million people in this country who had no insurance, and about 41 million people who had inadequate insurance, meaning that they were underinsured. The underinsured is defined as requiring more than 10% of one's income. If you spend more than 10% of your income on healthcare above and beyond insurance, then you're underinsured. COVID-19, it's estimated that there'll be a lot of people without insurance. I have on this slide 15 million. I just saw an article the other day that estimates that we may have as much as 40 million more people who are uninsured due to the COVID-19 epidemic. This means that somewhere around 110 million people in this country, close to a third of the country, will have inadequate health insurance if we continue the way we are. The Medicare for All saves about $450 billion annually, according to the Lancet article, and it saves 68,000 lives per year. Most importantly, it is funded with less financial outlay than is currently incurred by employers and households paying for healthcare premiums combined with existing government allocations. So in general, what Medicare for All will do would be, number one, to provide some standardized charging, both for hospitals, for physicians, for procedures, for medical instruments, and do away with the outlandish way that we currently bill for these things. It would decrease the total amount that individuals would pay out of pocket currently, compared to what we currently pay. It would decrease the amount of money that the employers pay, and it would save a large number of lives. Now, there's a lot of more information that I could have gone into, but I don't want to spend too much time doing this. This article is actually extremely well done in my view, and points out, as have many other articles, that Medicare for All saves money, saves lives, and does it in a much more efficient way. So I think at this point, we were going to open it up for questions.
Absolutely. And John, thank you. We will actually be sending the link to that Lancet article after the presentation today. So please watch
Okay,
your email for that so
good.
people can
Okay.
can find out more about that. Thank you everyone for all of your great questions. I think this we've gotten a few about COVID-19. Carrie, I think this might be a good one for you. It says, I keep seeing in the news that COVID-19 is much more pervasive in areas with lower incomes. Have you found this to be true here in the Twin Cities?
Thanks, Jen. I think that without adequate testing in the communities that I know of, which is true, we don't have adequate adequate testing in the communities that I know of in the Twin Cities. It's pretty hard to have a definitive answer to that. But I do know that we have really quickly rising positive test results in the clinic. And I think we could have mitigated a lot of that early on if we had adequate structure, testing, PPE, focused more on our preparation for a pandemic like this and less on saving money all the time. So, I think I would have to look more into the actual numbers behind that before giving a definitive answer, but I believe it could be true.
Great. And as long as we've got you on the spot here, Rose and John talked a little about health care for U.S. residents. How about non-residents? And also maybe you want to share with everybody a bit of your background and where your heart for the movement is.
Sure. Yeah, I think it is very important to provide healthcare, especially basic healthcare, to everyone here when they are here. I think it's Senator John Marty that said, he's the author of the Minnesota Health Plan, who said, you don't know the tuberculosis status of the guy sitting next to you on the bus. So I think there is definitely a huge public health reason to provide basic health care to everyone in our country. We can mitigate a whole lot of public health issues, especially among lower income communities and, even in migrant communities that maybe aren't residents, if we just provide basic health care. So there is definitely an issue there. I guess I'll share a little bit about my background, and can I just take it away, Jen?
Yes, please go ahead.
Okay, I would love to share with you all a little bit of my story, both my personal story and about my work that I do, and how that ties into a blaringly obvious need for Medicare for all in this country and in this state. So, like I had mentioned, and Jen kind of mentioned, I work in healthcare for low-income individuals, primarily low-income individuals, and my background is in public health. I focused in reducing health disparities, and boy, do I have my work cut out every day in this system that we work in. I really got into this fight for healthcare justice from a personal background. I had my own struggles early on in healthcare, navigating health insurance in our complex, expensive system. I was born with a connective tissue disorder that, among the many things it affects in my life, it includes my heart, and that has meant a lot of costly surgeries and lifelong complex healthcare needs. And like many Americans, I grew up pretty low income myself. My mom raised myself and my 4 siblings on an 8th grade education, fast food worker's salary, which obviously does not offer healthcare coverage. My father was a dairy farmer in rural Minnesota, so of course that doesn't come with healthcare coverage either. After my diagnosis, he did end up getting a job off the farm to gain coverage that didn't bankrupt the family, but still throughout my entire childhood, the chronic condition that I had, of course it's genetic, so found out some other family members had it as well, meant an ongoing battle between balancing the cost of my medical care and medical care for the family with keeping food on the table and a roof over our head. And sadly, it's a reality for a lot of people in this country. I was first sued by a hospital, which really took it to the next level. Personally sued by a hospital for seeking life-saving care at the age of 18. Like many young Americans and many of all ages in this country, I was not very good at navigating this really complex system, and the cards were honestly stacked against me. I hadn't been keeping up with my cardiologist because the thousands of dollars of a deductible at the age of 18, and on top of that, co-insurance of 20% for any specialty care was just absurd. I could not afford that as a young person living paycheck to paycheck. So I delayed care. I wasn't keeping up with the basic needs that I had, and a scary incident occurred, and I ended up in the emergency room. I ended up with a bill for several $1,000s in the end anyway, and of course, no way of paying. And like happens for many Americans with exorbitant medical bills, that bill went right in a pile until I was sued by the system. That really should not have taken me facing homelessness as a young person with a bright future and a health condition I was born with and I couldn't control, to realize just how broken our health system is. As many times as I experienced over and over our broken system, it became really apparent to me at that point how widespread and seriously it is crippling people's lives all across the country. So at that time, I was working in social services, pretty entry level, but it also became really apparent to me how inequitable these issues are, not only for, you know, young white people like myself from rural Minnesota, and what my family had to go through and myself had to go through to, you know, just stay alive and receive basic health care, but also how divided we are as a country upon racial lines, ethnic lines, and social class lines. And it's really, it was really heartbreaking for me to watch that at that time. Most of the people that came into my work at that time to receive food or free healthcare had severely neglected medical issues. And I realized that the people of color that we served were by far worse off. There is some research that was done. This has been researched a lot. The inequitable health outcomes in our country. Whites live a lot longer than non-whites in this country. There's racial and ethnic disparities like crazy, but so much of that is brought about by our healthcare system. Research in 2016 showed that Black families in the US are far more likely to be in the exact situation I was in, needing to borrow money, being put in collections, being sued, or declaring bankruptcy due to basic medical expenses. Now, that is not to say that this system is just or fair to anyone almost. It is definitely an unjust system in many ways to many people, but it definitely perpetuates cycles of poverty and structural racism for those that are already worse off. And the bottom line is alleviating problems in health access and cost for all Americans, like John and Rose so eloquently stated, would not only improve health outcomes and save us money overall, but would close serious racial, economic equality gaps, and health outcomes. Since my personal story at the age of 18, I have since graduated with my professional education in public health, focused in relieving health disparities. And like I said, it is very challenging in the system that we have. And without serious reform of our healthcare system, it's definitely not something that we will ever achieve in this country. So my work now is in clinical quality improvement in community clinics serving mostly North Minneapolis. For those that aren't so familiar with the cities, North Minneapolis is a historically Black neighborhood. It was pretty segregated. Most of the residents here are low-income people of color. And our patients also reflect that demographic. Our patient population is primarily Black, about a third Black identifying, about a third Hispanic, and then the rest are a mix of low-income white and other minority groups. We're a primary care clinic that serves folks almost entirely relying on public funding, and we are absurdly underfunded to reach a lot of people with a lot of primary care services, especially uninsured people in our community. The health struggles that our patients face are often very hidden from the public eye, but are the epitome of the need for single-payer healthcare in the US, and the structural racism, honestly, that our system has built. The racial gaps in insurance coverage is, first of all, astoundingly obvious. Even with our full-time navigators that will enroll you in our sliding fee scale options, we have Medicaid enrollment help. We have folks that will help you enroll in other insurance options. Even with all of those, the access to healthcare is still abundant. Our sliding fee scale is still very unaffordable for many. You can be seen for $75 per visit if you're up to 200% of the federal poverty level, which I think for an individual is $24,000 a year right now, which is not a lot of money. That's still a pretty small number to live off of with rent in the city, food. I mean, I'm sure you all know if you've ever lived off that number or known someone that has. If you have a chronic condition like diabetes or hypertension where you need to be seeking care every few weeks, or if you have medication costs, even that $75 bill for an entire visit is really unattainable. And many of our patients have a lot of barriers to Medicaid as well, especially our immigrant population. With recent public charge rulings, they could lose their resident status and never become a citizen if they enroll in Medicaid. So of course, they're going to choose to stay uninsured to stay here. So there are tons of barriers that introduce so many inequitable outcomes. I see patients again and again follow the same path I did in being unable to access basic care for their conditions, leading to far more complex problems, expensive emergency care and hospitalizations, and often I'm auditing their charts and they have a premature death outcome. This trend of delaying care until it is very complex is unnecessarily costly for all of us. Our hospitals just cost shift the money they aren't able to get from those individuals unable to pay to the rest of us, leading to higher bills all around. And sometimes public funding supplements uneven proportions of costs, which can just be spent on basic healthcare for folks. Everyone can just get preventive care at the basic level rather than spending that public funding on delayed, expensive care. Much of my job involves attempting to reduce health disparities, such as closing racial gaps in cancer screenings. We know our Black community members receive life-saving screenings cancer screenings at a much lower rate compared to our white community members. And that is tied to higher mortality rates, higher cost in the long run, and inequitable outcomes overall. When people are so afraid of healthcare costs that they delay preventive screenings, we have a big challenge ahead of us in closing racial gaps. Though we've made great strides in increasing our screening rates and closing racial gaps, our work still falls extremely short. First of all, if we screen someone and they have no insurance and we find they do have cancer, what do we do then for them? Our sliding fee scale does not cover that $6,000 diagnostic colonoscopy, let alone cancer for treatment. We can only serve them within our four walls with what we have, and that is all the healthcare that an uninsured resident of this community has. I've personally felt the pain of this dilemma many Americans face with delaying cancer treatment due to cost. While uninsured after a life circumstance in 2018, my own mother delayed lung cancer treatment due to the cost. Luckily, she did receive treatment before the cancer metastasized, but the fact that she needed to put her own life at risk in order to keep a roof over her head and food in her stomach while she waited for coverage was heartbreaking and very stressful. Perhaps even more heartbreaking, though, is that 33% of Americans delayed medical treatment due to cost last year. This does tie for an all-time high and shows a really scary trend in our country. I constantly battle with my role to advance quality of care and the quality of the population around me, the population outcomes. How can we provide high quality healthcare in our system, this broken system that we have, especially to those 350,000 and very quickly growing uninsured Minnesotans? Our physicians are burned out working in this system. They don't want to hear me say that one of their asthmatic patients is hospitalized for the 5th time this year because they couldn't afford their controller medication that was prescribed during their most recent check-in. And the hypertension control problem for people attempting to navigate uninsurance and this complicated system is just so beyond our capacity. I know how scary a cardiologist bill is and how hard it is to navigate maintaining continuous care, even while being fully insured. I honestly, my heart really goes out to all of our patients who have to do that with no insurance and constantly battling the cost of just basic needs like healthcare. And I know that neither my story nor this issue of federally qualified health centers, community clinics, like the one I work in, fighting the uphill battle of providing healthcare to uninsured, underinsured Minnesotans are unique stories. Health centers like the one I work at serve nearly 30 million Americans each year, but unfortunately only about 7 million of the country's, I think Dr. Crossan said there were currently 37 million uninsured. So that leaves a very high number of uninsured people not accessing primary health care that is affordable to them. And the cost of delaying care to that extent has a serious public health impact, let alone the financial impact it has on our entire society and those families and individuals. So we need reform that is equitable, that includes everyone, that breaks down this broken, expensive patchwork of a racist healthcare structure that we've built in this country. And an improved and expanded Medicare for all is the only plan that checks all the boxes we desperately need. That's all I have for you. Thank you for listening to my story.
Thank you, Carrie, for sharing your story. Looks like John would like to respond and share something as well.
Uh, Kari, thank you so much for that story that you told and the story of your current experience in healthcare. Um, Stories are the most powerful way to educate people. And I think if we can get some more stories to our legislatures that maybe they can be educated. The question about the death rate among African Americans with the COVID virus, I think if you look at the national figures, the death rate among the African Americans is much, much higher than it is among the Caucasians in this country. And that is because that the uninsured people have a very short half-life or a short lifespan compared to most of the rest of us who have some degree of privilege in this society. I wanted to read something very briefly from the Lancet article because it does address this. Universal coverage removes barriers to accessing existing primary and preventive care, and a single payer system incentivizes the expansion of preventive programs. Preventive care reduces the incidence of a myriad of diseases, including type 2 diabetes, heart disease, osteoporosis, etc. And what Carrie said about the fact that individuals put off seeing physicians because they're afraid of the expense actually just adds more expense to them as well as to the whole system. If people go in and get care immediately when they actually begin to develop something, it does allow good preventive systems to be put in place. It significantly decreases the number of people who present to emergency rooms because they don't get so extremely sick that they have to go to the emergency room. And actually, for some people, emergency rooms are the only place they can get care because we do have a law that people cannot be turned away from an emergency room if they present themselves just because they don't have insurance. And I have all kinds of stories about that, but I'm not going to go into them. But this is one way in which we reduce expenses, and that is have people go to their primary care when they need it and not present to emergency rooms. So I'll turn it over to Jen to go ahead with the program.
Thank you, John. And Carrie, again, thank you so much for sharing your story. I think that sadly, there are so many people who have similar stories to you, and that's why people come to this movement, is because they have felt the frustration of the current system and how little sense it makes. Jenna, I was wondering if you could share with us, as a future physician and the future of healthcare, can you share with us, I'm sure hearing all of these things, it seems like a very steep uphill battle. Can you share with us your involvement with the movement?
Yes, absolutely. I'll be a little bit briefer, but I'll share, yeah, my little spiel for you all. So my name is Jenna. I'm a first-year medical student here at the University of Minnesota, and I just want to thank you all for being here today. I'm super excited to talk with you about healthcare reform, and there's already been so much good discussion that we've had so far. So I just want to say up front that I understand that this is a politically charged issue, and everyone brings their own unique perspectives to the table and their own lived experiences, and just want to acknowledge that so that we can have a better discussion, more open. So I'm here to share my perspective as a medical student and as someone who has spent the past 7 years working and volunteering in various hospitals in multiple different states. So I believe that a universal payer system like Medicare for All is absolutely essential for improving the lives and the health of the people in this country. And you've heard many compelling arguments from our previous panelists before me, and I'm just going to briefly add my own reasons, and then I'll tell you kind of my vision for the future here. So I volunteered in both an adult cancer center and a children's cancer unit for several years, and I've worked with lots of different families during that time. And the common thread among them all is a constant concern about finances, in addition to the already constant worry about their family members' health. and the amount of medical debt from copays and deductibles can easily become insurmountable. The fact is, this can bankrupt a family, as we've heard, and even one with an insurance plan. Having an insurance plan doesn't stop you from having all of these copays and deductibles. And at a time when you're struggling with your health or a family member's health, you shouldn't have to also be worried that you won't be able to pay for your care, or that you'll finally get better and then have a mountain of medical debt that will take years to overcome. And to me, it seems obvious that getting sick should not bankrupt you, and I hope I can convince you of that. These are stories we can all relate to. We've all either been that patient or known someone who's been that patient that's been really sick in the hospital and also dealing with all of these medical and financial problems. We've also all experienced the less extreme burdens of our current system. We've all experienced finding a doctor or a provider that we like, and then our employer switches to a different insurance plan, and now they're out of our network, and we don't get to see them anymore. We've all had to spend hours on the phone with the insurance company to argue about covering a medication or a treatment that our doctor has already ordered for us and wants us to take. Our goal as physicians is to provide the best care we can to our patients, but in our current system, it is impossible to do this without also considering if our patients will be able to afford that care. And we aren't truly fulfilling our commitment to our patients if we aren't providing them with the absolute best care we can. And frankly, we're failing them. But my hope is that we will join the rest of the developed nations in the world to provide universal health care. I want a system where the goal is to provide the best care for my patients and not to make a profit, and I believe that view is very widely shared. I want to briefly discuss how your own experience with the healthcare system would change if we accomplish this great reform. So right now, healthcare is tied to employment. And in fact, a lot of jobs don't even offer healthcare, like ride shares like Uber and Lyft, and waitressing jobs, contract work, the list goes on and on. But with Medicare for All, if you lose your job or you're self-employed, you will always have access to healthcare. You will always have the freedom to choose your own doctors or providers. And with Medicare for all hospitals and clinics will be quote unquote in network. There will be no such thing as out of network. You will never end up with a huge bill that you can never pay. You'll leave your doctor's office without having to pay very high copays. And you won't have to spend hours on the phone arguing with an insurer about covering a medication or treatment your doctor ordered. Frankly, I want those hours of my life back as well. I'm sure you all do. And as it's been pointed out earlier, a universal payer system will make healthcare in this country cheaper. And my hope is that as a future physician, I'll provide care to my patients, not based on the care they can afford, but the care they need. And we all want the best care possible because it's our lives and our families' lives on the lines, and that's why we need Medicare for all. And I'm really excited for this movement to go forward and hopefully for legislators to take action and protect people living in this country and make healthcare better for everyone. So thank you all for listening, and all of your questions have been wonderful.
Wonderful. Thank you so much, Jenna. I think it is great to hear such hope for our future. And I would love to point out we have this great question currently that says there are so many great organizations fighting for Medicare for all. And the problem seems to be that they don't work together in a unified way. I would love to point out that we have a future physician, retired physician. We have the Minnesota Nurses Association. We have public health. Also helping us out today is a lovely gal named Dana, and she works with Healthcare for All Minnesota. She is helping with this event. And I think it's important to see that we can make a difference when we all work together. So the question here is there any hope of forming an organized coalition to solve this problem? And maybe just added to that, what can citizens do to help further this movement? Go ahead, John.
Well, I'll start, and then I want Rose to comment on this. This has been one of my banes of contention for a long time. We have a whole bunch of organizations in the country and in the state, all of which are aiming for the same thing. And I have no idea why we don't work together. We do have these different organizations. And I think if we were to be able to work more closely together, that we would have more power. And I'd like to hear Rose's view on this, because she works with a huge group of people and understands the emotions and the interest in the part of the nurses in getting single payer. Rose, what do you have to say on this?
I think there are a lot of organizations that are working together. My goodness, the National Nurses United, our national affiliate, is running a Medicare for All national campaign. We are in Washington, D.C. We sit at a table with PNHP, with Healthcare Now, with the disability community. We are making sure to be inclusive of employers as well as employees. We, as part of the labor movement in this nation, are pressing and pushing the labor movement and the House of Labor to begin to understand that this is a pro-worker, pro-employer type of legislation. There would be nothing that would make us happier than to not have to deal with this issue on the bargaining table anymore. We can't, it's a failed strategy to think we can negotiate healthcare. We just yell at each other about how much, who's going to pay what on the rising costs, and we don't realize that we actually have a common enemy as labor and management when it comes to how this issue is treated. It is not a consumable good. You don't decide to have a heart attack one day just because they have a discount on bypass surgery at Allina. Healthcare doesn't work that way, and working together in the House of Labor with all these other organizations, Healthcare for All Minnesota, I sit on their board of directors. We work with our local PNHP chapter. So I'm not sure what folks are looking for, if they think there needs to be like one big national organization or umbrella that just says, here's how we're going to do it, and everybody's going to march to this drummer. I'm not sure that we actually do need it to be that specific. We are pushing this nationally all over the place, and not just in blue, progressive, liberal states. NNU is running campaigns with citizen organizers in the states of South Carolina and Florida and Texas and Arizona, because people care about this issue and they are tired of wasting their money and their time and not being able to get the health care that they need. So I think we're making more strides than folks realize.
I also just want to point out that one of the best things you can do as a person living anywhere is give your legislators a call and tell them that you are passionate about healthcare reform and that this is something that you want. And all of our voices together can get this, moving forward. And also another great thing to do is have a socially distanced Zoom call with your neighbors and friends and have a respectful conversation about why you feel that this is an important issue that needs to get passed. So that's my 2 cents on it.
Jen? I agree with all that you've said, and I do have a question. We now know that Medicare for All would be less expensive than our current system. We know that we will save lives. I cannot comprehend where the problem is. And Rose, you told a story the other day about Lyndon Johnson when he signed Medicare in 1965. Would you tell that story again, because it does deal with the big issue?
Well, rumor has it anyways that when they were working on the legislation in 1965 to pass Medicare, someone came into Lyndon Johnson's office and said, well, here's what the cost is. And it was costly. I will tell you, it was costly. And he looked at that number and he said, give me another number. And the reason he said that was because he said, I can't get it passed at that. This is the right thing to do. We will figure out how to pay for this because it is a priority to keep senior citizens healthy and be able to retire with dignity and access to health care. They shouldn't have to die homeless because of illness as we age and use more health care. It's the natural way of life. And he said, so get me the number I need to pass this bill and we'll deal with the rest of it later. So sometimes we get far too hung up on this issue around what's it going to cost, although I understand that's an issue because of what we're paying for it now. I can tell you that every single solitary study that has ever been done about single payer healthcare has shown, as John has said, that it will cover everyone, it will increase quality, it will decrease cost, and most importantly, it will save lives.
Thank you. That is so important, and I think that is the message that we need to get out to everyone. At the end of our presentation, we will be sharing resources so that people can get involved in their local communities here in Minnesota, across the nation as well. Dana is going to share some more questions with us.
Hi, can everybody hear me okay? Am I coming through? Okay.
Yeah, you sound great.
Great. You know, we've been talking about current Medicare a little bit, and there have been some questions about the Medicare reimbursement rates. So the current Medicare reimbursement rates, people think are too low, and can hospitals really survive on those? Can somebody address that one?
Yeah, I'm just typing I'm just typing a response to that in the actually in the chat, and I see John raised his hand. I'm sorry, John, I didn't mean
go
to
ahead.
jump in. I'll try this, my friend, and then you can sort of add on where I may have it right or wrong. But so right now, Medicare rates, reimbursement rates are too low. You're right, they're too low. Under a Medicare for All system, they're not going to be what they are right now. They will be it'll be a new negotiated rate, but you've got to understand our current system, it figured into all of these different reimbursement rates, which are different if you're insured, uninsured, if you've got Blue Cross Blue Shield versus Medica, if you have Medicaid versus S-CHIP, if you know, I mean, we're all over if you're the VA, TRICARE, oh my God, it's insanity. And a lot of the waste in the system is all of the fees to administer that incredibly complex, heavy system. We take the money we save by streamlining the payment system, and we use that to properly fund rural, urban, and suburban healthcare facilities so that they get the money they need to be able to provide the care that that community needs them to provide. There's another physician within PNHP Minnesota that I work with often, Dr. Ron Jankowski, and he was in private practice for a number of years, and he said he actually took some time to run the numbers once, and he thought to himself, what would happen to me if I just switched over to the current Medicare reimbursement rates, but I didn't have all of the administrative costs that I have to pay in just processing thousands of different types of plan options with insurance companies, and even government plans are somewhat, bifurcated now, right? He said he found out that he actually would be at about a break-even point, believe it or not. So this idea that even the current Medicare rates couldn't possibly support the system, well, I think they probably need to be increased, to be honest with you, but they can be when we want to focus and allocate dollars on care instead of all this other nonsense that has nothing to do with our health.
That's basically what I was going to say. The studies show that, in fact, the Medicare rates do come close to covering the cost of a practice if you eliminate all the extra administrative overhead that's involved, and you just have one biller and one payer, and the bills are straightforward. One of the things that Elizabeth Rosenthal emphasized in her book was that if some of these people, some of the people that she quoted having real serious problems had actually asked for an itemized bill from their hospital. And apparently, if you do this, you're going to get things all over the place. Some of the itemized bills talk about the cost of administering oxygen when in fact this patient never got oxygen during the hospital stay. So the billing is not only excessive, but it's wrong frequently. And I think that when we do go to Medicare for All, I think the Medicare reimbursement will come close to handling the costs for both the physicians and the carers as well as for the hospitals, because the hospitals will not be facing the huge costs that are really excessive by the providers of some of the instrumentation, the radiology instrumentation that we have, because these can also be negotiated, as well as negotiating the prices with the pharmaceuticals companies.
Thank you both. I do see another question that is sort of along the same lines. In terms of the rural hospitals, could you go over again how Medicare for All would be beneficial for rural hospitals?
Sure. So rural hospitals, a lot of them right now are run by major healthcare corporations, all part of the big medical industrial complex. And the decision on whether or not Mayo keeps Albert Lee facility open or begins to deplete it of many services that may be needed in that community, like, oh, I don't know, let's say labor and delivery. When you're along Highway 90 in southern Minnesota, a freeway that is often closed in the middle of winter, and where are women supposed to go to deliver a baby when they go into labor during that type of a situation, if they have to drive anywhere from 45 to 60 miles away in order to find the hospital that offers those services. Those decisions are being made right now based on the bottom dollar and the bottom line of those corporations, not necessarily what are the health needs of the community surrounding those facilities, particularly in our rural hospitals and rural communities around the country, not just Minnesota. So what Medicare for All does is it offers an opportunity for the regions of the state, for those areas to look and say, what type of health needs do we need here versus 50, 60 miles from here? Is that a reasonable length of roadway to have to drive for some types of procedures, but maybe not for others? How do we want to make sure that the community's medical needs are met, and then we fund those hospitals, whether they're critical access, acute care clinics, we fund them according to the needs of that community. And that's what we're able to do when we have global budgets and capital budgets versus everything being piecemeal and being determined by, quite frankly, where is there a population density area? Because if you build a hospital, you gotta fill a hospital in order to make money on it. And it shouldn't be about making money. It should be about providing health care for the community. So I hope that answers the question.
Let me just say a little bit more. I just read about a big conglomerate in the San Francisco, Sacramento area. And this big conglomerate has actually overtaken many of the small hospitals and the small clinics. And because of that, this big conglomerate was able to boost up its charges rather than reducing the charges. And so the conglomerate is making all kinds of money, including the people at the head of this conglomerate. I didn't mention earlier that when we have Medicare for All, the person who runs Medicare for All, his or her salary would be capped at, I think it's $270,000 a year, which is basically what the head of Health and Human Services makes in the government. And this is a livable wage. I don't know really of anybody who really can't survive and actually raise a family on $270,000. Whereas the heads of these conglomerates, once they get all the hospitals together and have no competition, these heads of these conglomerates make in the $2, $3, $4 million range. And so actually this Medicare for All will help to maintain hospitals in the rural communities. Rural healthcare right now is a serious problem, that's for sure.
All right, thank you.
Absolutely.
Thank you. I wonder if you could talk a little bit about state-based efforts to reach a universal single payer system, and also talk about the status of that in the state of Minnesota.
Hi, it's Rose again. Sure. So Senator Marty has a bill called the Minnesota Health Plan. Oh my gosh, Dana, I've been doing too many numbers here tonight. I'm trying to remember the number of John's bill. Is it S213 this year? Because it gets a different number every 2 years. So don't quote me on the exact number. Or Ann, I know, is on the call. So at the meeting, she might be able to tell me. I've forgotten the number. But the Minnesota Health Plan is specifically to try to do something as close to single payer as you can in a state. To be perfectly honest with you, it's harder to do true absolute single payer in a state because you would need to get the federal government to agree to allow the state to combine the Veterans Administration in with Medicare, you know, and also in with the Indian Health Bureau services, Indian Health Services. So we probably wouldn't end up with literally pure a state single payer, but other than those that I just mentioned that are covered under the federal government, we would have, everybody else would be covered under the Minnesota Health Plan. So if you're not on Medicare, or you are on Medicare, but of course you have to have that gap insurance or supplemental insurance, you wouldn't need that anymore. You would simply have the Minnesota Health Plan as your supplemental insurance to go along with Medicare to cover that that 20% gap that exists in our current Medicare system, which is why we talk about improved Medicare for all, because we want to cover 100%, right? We want to get rid of that 80-20 split. And you would, so the vets would still access the Veterans Administration for their health care, but everybody else would be covered under the Minnesota Health Plan. So that is was introduced in the legislature last year for the 2-year biennium session. It didn't even get a hearing in either the House or in the Senate. We have a long way to go in order to try and move that sort of legislation in the states. And the other thing we have to really think about at the state level is this issue with waivers. So currently under the Affordable Care Act, assuming that stays the law of the land, which, as you know, is being right now challenged in the Supreme Court by the Trump administration, if it remains the law, excuse me, the law of the land, they have something in there called 1332 waivers, and you have to request them as a state if you want to do something other than the Affordable Care Act through the exchanges. You have to make a request of the federal government, and you have to be able to provide health care at least as good as the Affordable Care Act, which of course it would, there's no problem there. And you have to be able to do it at no additional cost to the federal government, but you have to be able to convince them to keep giving you the subsidies that you would have received under the Affordable Care Act for those people who buy on the open exchanges, so that we can absorb that money and use it to pay for our state system. Needless to say, at least under the current administration, I think it would be pretty hard to get any sort of a waiver to do that kind of innovation at the state level, which is unfortunate, but I think that's sort of a reality that we have to you know, be aware of. Doesn't mean we don't continue to fight for it, because it's worth it. And you know, in Canada, they got healthcare, national healthcare up there by Saskatchewan province being the first one to actually put together healthcare for all of the citizens in Saskatchewan. And then the federal government looked at that and said, wow, you're doing a good job at this. This is great. I think we better think about maybe how can we help fund it and encourage the rest of the country to do the same thing. And that is how they actually got a national health program in Canada. So we should continue to fight for on the state level, but there certainly are hurdles that we will need to get over.
Thanks, Rose. I was also going to mention the 1332 waiver, which is a part of the Affordable Care Act and does allow Minnesota to provide a health care system that is actually better than currently in the United States. And I would just like to say that we in Minnesota have a chance to be the Saskatchewan of Canada, in that we could become the first state with true superior and then the rest of the United States will see what a good job we're doing and would follow along. I think that's a real possibility because we have some very strong bills in Minnesota, and we have a lot of people who are passionate about getting this.
Thank you, John. I agree. We do have a lot of passionate supporters. I think we need to continue to accumulate those and organize those and get them on our lists and be a force for change. So I know we're getting pretty long here. We do have a few more questions we could cover if you're okay with that. Is everybody okay with that? Panelists? Okay. So there's been a couple questions about coverage under Medicare for All, things like long-term care. How does it address vaccinations? And what would happen to concierge care, concierge practices?
So I'm not, John, I'm not sure if I know what you mean by concierge.
Yeah, right.
Are we just talking about like physicians who actually just take pay directly from the patient because the patient is able to pay them directly and the physician is actually able to provide care without going through either insurance or Medicare? Is that what we mean by concierge services?
Yeah.
Yes, I assume that.
Okay, so I believe it or not, I believe in both the bills in the Senate and the House, there is a provision that allows that to continue. I will tell you that, and John, again, you can tell me if I'm wrong on this, but I'm going to say that somewhere around maybe 99% of most of the doctors in this country wouldn't consider doing that. They would provide care through the system. They would know that they have a steady income and a steady revenue stream that would pay them fairly for the services they provide. I mean, folks think that in a healthcare system like a single payer system that somehow physicians and nurses would have to also have their pay docked or lose money. Well, there is some disparities between, say, specialists in, again, I'll compare to Canada versus the United States. So an anesthesiologist might make $500,000 a year in income in Canada and may make more like closer to $1 million in, or 700,000 or so here in the United States. But a primary care physician in Canada actually makes more money than a primary care physician or the average primary care physicians in the United States, because they put an emphasis on the front end of healthcare with primary care. So their physicians, their primary care are making $200,000 to $250,000 a year. Physicians save our lives. They should be paid accordingly to the work that they do and the service that they provide us. Nobody is looking to balance a healthcare system on the backs of the people who actually provide us with care. So there is a way to ensure that we are paying people for what they are providing, and that is through that system, which is why I think for the most part, physicians would, sure, if they want to do that concierge service, it is actually available to do it. I just don't think there's going to be too many of them that are going to do it.
Thank you. And then
I would definitely agree with that. I think there probably would be a very small concierge system in the United States. I believe even England has a small concierge system that exists in spite of their very strong universal healthcare system, which is actually extremely good. The issue of vaccinations falls under the area of preventive care. And one of the things that all of the single payer bills provide is strong preventive care. And they emphasize the importance of preventive care, and vaccinations are a part of preventive care. And so there definitely would be vaccinations, as well as very strong emphasis on preventive care, which we don't have in this country. Right now we have sick care, not health care.
thank you. And it's my understanding that long-term care is also covered. Isn't that correct in Medicare for All bills?
So in the state bill, it is in HR 1384. It is covered. Senator Sanders' bill has left long-term care under a Medicaid system during a transition period. So we've got some work to do again to make his bill much more simpatico with the House bill, which is without a doubt the strongest, most comprehensive single-payer healthcare bill that has ever been introduced in the United States Congress ever in its history. And it has, I believe, 120 plus co-sponsors of that bill as well. So that's really the gold standard that we need to strive for.
Okay, thank you. Then lastly, I think this pretty much sums up the rest of the questions that deal with our topic. People are wondering, how do we fight against the medical industrial complex and their money? And how do we convince politicians like the presumptive Democratic nominee, Vice President Biden, how to support this this reform?
It's all about us. It's going to take a movement. There's no easy answer to this question. I wish there was, but the reality is that they're not going to do it until we make them do it. And so it's about doing things like we're doing here tonight, continuing to have these conversations one-on-one with one another, try to allay people's fears about what we're talking about here, because health is very personal to us as humans, and it is scary when we think about changing something as dramatic as how we're going to access our health care. We have to listen to people, hear their stories, because I got to tell you, I don't know a person I've met yet that who either doesn't personally or have a family member or a friend who unfortunately has had a healthcare horror story situation impact them. We raise those up and we say, we offer hope. We say it doesn't have to be this way. Let's talk about what you would like a healthcare system to look like. And guess what? We can make that happen. But it's going to take all of us to get on the phones, to talk to one another and create the movement that's going to make them do it. Because until the demand exists out here, they're going to continue to just think that they can tweak and nibble around the edges of this thing, and somehow it's going to be enough to fix it. They're getting a lot of money and a lot of pressure, as was noted, from the industry itself. And we may not have the money, but we got the people, and we've got the moral outrage about what's happening in this country around healthcare. So we just got to turn that into action and organize and mobilize, and we'll get there, and we're doing that.
Absolutely. Yes, John.
This, I believe, is going to occur because not because of Vice President Biden being president, which he may be, but it'll occur because of people in the House and the Senate passing a bill that he can't possibly turn down. I'm not too concerned about him being an obstacle to this. I have been pushing in Minnesota for us to think about having a 500,000 person march on the Capitol as a way of trying to get John Marty's bill passed. And I think that this type of outcry by the populace is going to bring it about. We don't accomplish these things from up top. We accomplish it from the bottom with movements like the individuals' movements.
Absolutely. And we thank everyone who joined us tonight for this discussion. This is an advocacy opportunity for everyone. And so we will be sharing some resources, and we truly hope that you will join our movement. We hope that you will join us. We have many opportunities. If you go to pnhpminnesota.org, hca-mn.org, you can sign up, you can get involved. We will be sending out action alerts. in the upcoming months. Of course, we will be doing it from an appropriate socially distant way. We won't be able to do our 500,000 march quite yet, but we'll get there, and together we can make a difference. We'd like to thank our panel today for this wonderful discussion. Thank you for everything that you've shared with us. And for all of our attendees, we will be following up with an email with resources discussed during the presentation and also presented before you now. So thank you everyone for joining us, and we hope that you will complete our post-webinar survey. We really appreciate your feedback, and we hope to see you at future events. Thank you so much. Stay well.